Thank you so much, Beri, and thank you, Paul, for being here and lending your stature to this event. And thank you to everybody for being here. I know everybody's super busy. Everybody had to come from Excel or go back to Excel. Joanne Pike, who's the head of the Alzheimer's Association, a special big thank you. Come on up here. This is a big, big event for the Alzheimer's Association. 8,000 people gathered here, and she made the time to come out here, which is really terrific. And she gave a fiery, she said, I think fiery is, you're saying a little bit too much, but I call it a fiery speech yesterday, talking about why science should not be political and why we need to invest in science, protect science, and medical research, which I was like, yeah, go girl. So I'm so glad that she's here. And when 2010, I partnered with the Alzheimer's Association to do a Shriver report to look at whether this disease disproportionately impacted women. My dad had been diagnosed in 2003, and as I went around the state of California, because I happen to be the First Lady of California, seeing so many women and asking doctors, is this disproportionate to women? They said, no, you just think that, because women live longer, but that's not correct. So I thought, yeah, I don't know about that. And so we partnered with the Alzheimer's Association in 2010. We reported out for the very first time that this did, in fact, disproportionately impact women. 2/3 of those who get Alzheimer's every 65 seconds are women. And as Beri alluded to, when we went to understand why that was the case, we were told, well, we don't know, because all the research, not just in the Alzheimer's space, but in women's health in general, has been done on men. Which then lit a fire under my butt. And I was like, okay, well, we've got to change that. And so we started the Women's Alzheimer's movement coming out of that report. And I'm very grateful for the relationship we've had since then. As the film said, we went on to partner in 2015-16 with Cleveland Clinic. Once we started this pilot center at the Women's Alzheimer's Prevention Center to see if there were lifestyle changes that women could begin to implement in their life. Did that slowly perhaps prevent or delay the onset of Alzheimer's if women actually began to believe that they had agency? Everybody at the time was saying lifestyle has no impact whatsoever on Alzheimer's and dementia. And I bring these up just because, you know, prevailing wisdom isn't always the wisdom, and it can be changed in real time and in real life. So that's an important thing, I think, to remember, because we now know that perhaps 50% of these cases can be preventable due to lifestyle changes, the finger study, the pointer study, et cetera. So I think that's a really exciting change in this space, that everybody said, oh, nothing has happened in the Alzheimer's space, which of course is the wrong story, which I hope will come out of AAIC, that so much has changed and is changing. And that, of course, is one of them. And then we're so glad to have partnered with the Cleveland Clinic to really amplify the work that WAM has been doing, and then help women as they come in very often at midlife with menopausal symptoms that include cognitive issues, that WAM serves really as a bridge at the Women's Health and Research Center over also to neurology. So if women come in complaining of cognitive issues, wanting to know more about brain health, they can get the help that they need at the Women's Comprehensive Center, but then they can also go over to neurology if it's a more acute case. So I think that's really innovative and trailblazing, really, and I'm so glad to be a part of that, and I'm thrilled that it's now going to be here in London, because as we all know, this is a global issue. I'm also really thrilled, speaking of global issue, to have Hilary Evans-Newton here, who runs UK research for Alzheimer's, the Alzheimer's Research Institute here, so I hope you'll come up, because we want to talk about what you're doing here in London and what your vision is for this global issue as well. And Dr. Rachel Buckley, who is one of the leading researchers in women's brain research, women and Alzheimer's, and is going to bring us up to date about what we should know, what we can look forward to, where are those sticking points, and how we can, looking forward. And as I said to all of them as we came out to do this panel, and I think I would like to try to open it up also for questions as we get through it, because people have so many questions. But I wanted to start with Joanne because I said to Joanne before we did this, let's start about where we were in 2010 with the belief that women were not disproportionately impacted at all by this disease. We didn't need anything. We didn't need to look at sex differences. Where do you think we are now at AAIC in 2026? And then we'll get to where do we need to go.
In the past 16 years, there's certainly been a lot of ground covered and a lot of changes, especially in the last 3 to 5 in particular. And I think it's important to reflect on not only where were we in 2010, but some of the incremental changes that have occurred since then that have led and compounded to the point where we are seeing a snowballing impact of innovation coming to the marketplace right now. I think it's a matter of now making sure that that innovation applies to everyone. And that we're able to implement that. And I think there's some things within that time period that as a patient advocacy organization, as a research advocacy organization like Hillary, and as a funder of science, where we're going to be able to hear from scientists, that we can begin to think about how do those moments within the last 16 years really apply to women, but Alzheimer's and dementia science broadly. You know, since 2010, we have seen a significant increase in governmental, philanthropic, research dollars going into the market. And that compounding effect year over year is really building to more outcomes. Back in 2010, as an example, in the US, we were probably spending only about $400 million per year in governmental federal funding for Alzheimer's and dementia science. Today, that's $3.9 billion. There is a significant gain within that. I imagine the UK could tell a similar story within that time frame. Within there, we also began to diagnose people accurately based on biomarkers, which leads to better targeting of treatments that actually are built for the biomarkers that someone is seeing those changes in their actual brain versus studying people who don't have the biomarkers. So there's been a significant shift on that front. Enrollment and ensuring parity in enrollment, representation in enrollment has been an incredible focus over that time period. And you mentioned lifestyle. We certainly could guess, we could assume that what we can do from a risk reduction standpoint or a lifestyle perspective would make a difference on your brain health, but now we can definitively say that yes, it does. We learned that with the finger study when it came out in about the mid 2015, 2016 time period, and then we applied that to the US, and that's being applied in multiple other places around the world now, where we know that a regimented lifestyle intervention can improve and save cognition over a certain time period. And actually, right now over at AAIC, speaking of good science being reported out, we're hearing about the Latin American finger study that is reporting out that same success, that in Latin America they were able to apply the fingers, the pointer recipe, and show that you can save or have a 50% improvement in cognition for those who do a lifestyle intervention. So there are lots of points within this. Now, how does that apply to women and where we are with our knowledge? I know, you're like, come on, get to the point, Joanne. There has been growth within that too. And you mentioned that when we started back in 2010, we were studying men. Or we weren't thinking about the sex differences. There was a report actually, and someone can correct me around here, maybe the scientists, I think it was back in 2022, that actually showed that now representation in clinical trials is up to 58% women in Alzheimer's and dementia science broadly. So we have changed that. We're now studying women. Now it's a matter of reporting the differences that we are seeing within that. And as we're seeing innovation come to the marketplace, we have to ensure that the things we are seeing, whether that's biomarkers or treatment, that we are responding in the same fashion across the population.
So that's super exciting to see kind of the change in investment, the change of women being included in trials and women volunteering. That's the thing that we're seeing a lot, like at the Women's Alzheimer's Prevention Center. Women who came there were like, sign me up. I want to be, if it's not going to help me, I want it to help somebody who comes after me. And more, we have a huge brain study at the Cleveland Clinic, overwhelmingly women, sign me up, sign me up. I want my brain to be of service. I want to be of service. I want to be a part of finding a cure. But Rachel, tell us exactly kind of when Joanne talked about we have to study sex differences is one thing, but we have to report out the findings of those sex differences. Where are we and where do we need to be?
Absolutely right, and it's a wonderful point that you make. And also I just wanted to give a shout out in the audience to all of my allies in the room, the scientists who are with me every single day.
I should say, I don't know if I said that Rachel's at Harvard, and she's also very jumped in because Lisa Mosconi, who is a WAM grantee, was supposed to be here, and her dad died in his sleep last night, so she had to run out this morning. And Rachel and Lisa are colleagues on
very
the
close
Welcome,
friends. Very close friends. My heart goes out to her.
And colleagues on the Welcome Lead Care Study,
That's
which is looking at women and Alzheimer's. And then Rachel, obviously, in her own lab at Harvard, looks at this. So go ahead.
Yeah, so I'm an associate professor of neurology at Massachusetts General Brigham in Boston, even though my accent is not indicating that region. I'm from Australia originally. So what we've been really advocating for as a group, as a body of research scientists who are really interested in optimizing women's brain health when we're thinking about chronic disease, specifically Alzheimer's research, that's my area of passion. We're really focused on sex disaggregation. When we're thinking about clinical trials, reporting and outcomes, we need to know both adverse events and we need to know response to treatment. And this will be true not only in symptomatic patients, as we're starting to really see these wonderful treatments being rolled out, but also in the coming 12, 18, 24 months, touch wood, that we might see success even in cognitively unimpaired individuals, these trials being rolled out in secondary prevention. And it's there that we will need to, again, really understand what we're thinking about with treatment and adverse outcomes in women and men, not just as a global group, because women are not just little men. We've known this for a long time. And so...
Not that long.
No, well, perhaps not. Perhaps not. You're right, Maria. And it is something, it's not just, every day I'm sitting at my computer and all I think about is sex. But actually out there in the real world, that's not always the case. And I need to be getting away from my computer and really arguing for this more.
But Rachel, so many people come up to me and they say, I know, thank you for what you're doing for Alzheimer's. I know you're really in it, but why do you always talk about women? Why don't you just talk about Alzheimer's? After all, it was your dad that had Alzheimer's. Just talk about, Alzheimer's. Why women? And I say, well, women are the majority, so studying women might yield us the answers for everybody. And they're like, no, it won't. It's just talk about Alzheimer's. Well, why is it important to have this conversation, to focus on women at this particular time?
I love that you asked me that question, because when you think about Alzheimer's disease, really women are at the center of that story. You've heard the statistics already. I don't need to roll those out again. But clearly, there is a difference in how women and men manifest this disease. The interesting statistic, actually, that some of you may not be so familiar with, is even though the prevalence rate, so if I capture everyone in this room and I just count how many people have dementia, women definitely there are many more women, 2 to 1, 3, It's really outweighed. But if you think of incidence rates, if we capture everyone in this room and we see who progresses to dementia in that period of time, in fact, women and men in some studies are actually very similar. Quite a few studies across the world. That's quite surprising to people. And they immediately think, well, there are no sex differences. But I disagree entirely, and my colleagues would agree the same, because of the findings that we've seen consistently, time and time again now, that the manifestation, how the disease takes hold, and in fact, potentially the drivers of the disease are very sex specific, and there are some things that overlap, but we see very interesting differences between men and women.
And won't that impact the drugs that men and women get, the dosing that men and women get?
Exactly.
How do things go to the blood-brain barrier? Are women's blood-brain barriers different than men? Are the dosing that you would be giving or that Cleveland Clinic would be giving here, shouldn't it be adjusted for sex differences?
There's always that potential. As a scientist, I'm always going to be very conservative. We always need to dig in further. That is the point of sex disaggregation. What that means is we need to report. Even if we're not statistically powered to test some of these findings, we need to report them for the general community, the scientific community, to learn, to know what to do next, to find the next funding to be able to drive that field forward. What I do, if I had to put my money on it, I would potentially say there might be more sort of personalized medicine approaches. If you are a woman with certain risk factors, and it could be reproductive or it could be menopause related, relative to men, but again, these are areas that we still need to know more about.
Rachel, let's talk a little bit about what you're doing here in the UK. I read that dementia and Alzheimer's, the #1 killer of women here. In the United States, it's #6. What are you were saying to me, I said, why that discrepancy? How can it be #1 here and #6 there? And after all, I think it's super important because we're talking always about Alzheimer's and dementia as a global issue. So what is at the root of that?
Yeah, I think it's interesting. So in the UK, dementia has been classed as the leading cause of death for women since 2011. And probably one of the reasons is how we capture that on death certificates in the UK as opposed to the US. So we would capture someone dying with dementia. So they may die from pneumonia, but they will have dementia. Whereas in the US, I think they categorise death certificates slightly differently. But I think capturing that data is really, really important. So I think we've had a really clear picture in the UK that this is a condition that disproportionately affects women. And as Alzheimer's Research UK, and in the time that I've been with the organisation, which is about 13 years, it's been a big priority for us. So we did one of the first reports on women and dementia, looking at, I guess, a sort of triple whammy effect that dementia has on women. So obviously we've heard 2/3 of women, 2/3 of people living with dementia are women. We also know that, the predominantly caregivers are women in society and with families, so paid and unpaid caregivers. And then looking as a scientific funder, looking at how we're funding scientists, what the diversity of our scientific funding looks like, what the scientific leadership looks like. That is improving, which is fantastic. But then, are we asking the right questions as a scientific funder? Are we ensuring that things like a women's health strategy is focused on brain health and understanding some of these differences? And I think that is starting to change. And I think in the last 10 years, we've seen some really big shifts in doing that. And I think that one of the things that has really helped us is probably that sort of advocacy movement, is actually to go out there and talk to the public about this and to motivate women to stand up and talk about their own experiences within their families. They're often the ones that are, the ones taking their husbands to the doctors, and actually who's then advocating, looking after them. So I think that, for us, actually, we've seen a real sort of change from a scientific funder in terms of ensuring that everything that we are funding and all of our grants are asking these questions, and that's baked in. But I guess on a sort of data point, ensuring we've got the data that our scientists can work from, so understanding everything from the basic science all the way through to clinical trials.
So Hilary, on Friday, you had a big major announcement here in the UK where you wanted to look at Alzheimer's and dementia really as a global issue, but you wanted to bring in many stakeholders into one organization and attack it in a different way. Can you tell us a little bit about that?
Sure. So I chair a government workforce task force in the Office of Life Sciences. So that sits between the Department of Health and our sort of innovation and trade departments in the UK government. And for the past 3 years, we have been looking at what in the kind of dementia ecosystem is happening in the UK. Where are the opportunities? We've got brilliant neuroscience, we've got some great clinical data, We don't yet have access to disease-modifying therapies on the NHS. There's some big, big challenges.
Pause on that. Just repeat that, because that's a big issue.
Yeah, that's a big issue.
We do not have access to disease-modifying drugs. We just heard that we did here at the Cleveland Clinic for a very small, which is a private hospital. Why is that?
Not on the NHS at the moment. So so for those kind of not au fait with the UK system, in order to get access to drugs through the NHS, you have to essentially have approval from NICE. So this is the body that looks at what's cost effective for the NHS to sort of purchase those drugs. So we are in the 4th round, I think, now of a NICE appraisal. So they look at cost effectiveness of these drugs. So we had a meeting last week that are looking at Leqembi and donanemab. So we should hear in the next few weeks as to what the outcome of those meetings have been. So either that will be an approval or a conditional approval, so maybe looking at sort of a managed access scheme that a small number of people and a small number of centres would have access to these therapies, or we're back to the drawing board and it's a no, and either we wait for the next application or there's a continued appeal. So that is a challenge. So the UK government acknowledged that there was a lot of work we needed to do, and yet when as a country we came together around COVID, we had a COVID task force, and essentially that brought together sort of doctors and scientists and government leadership to think, right, how can we do this differently? Who do we need to work with? What's the funding that's needed? And so we have applied that sort of thinking to dementia. And this programme is called the Dementia Goals Programme. It's the Dame Barbara Windsor Dementia Goals Programme. And Dame Barbara Windsor, who's widow Scott Mitchell, joins us actually here today, and Scott's been an incredible campaigner and advocate for this programme, was then backed by £150 million of government funding. And Dame Barbara was very public about her own diagnosis of Alzheimer's disease. So again, back to kind of women stepping up, talking about her own diagnosis, and really kind of following that over the few years until 5 years ago when she sadly passed away. But actually her legacy really, really does live on in this programme. And so the initiative that we launched on Friday is the Barbara Alliance. And this Barbara Alliance is a brain ageing repository. So the acronym does work, and I can't even remember every bit of it, but it's essentially pooling a number of the different clinical cohorts that we've got together in the UK, and then thinking about it from an industry lens. So we have got a public-private partnership that is backed by industry, global philanthropy, UK charities, and the government. It's match funded with government funding. And this is really to look at, how we can create trial-ready cohorts in the UK. So making the UK more of a destination for industry to come and run these clinical trials, but ensuring to that data point that we've got all of that data there already. But because we have the NHS, and there are challenges with the NHS in getting treatments to patients, but what we do have in the NHS is brilliant clinical data. So how do we make the most of that? And that, in turn, will allow people access to the next tranche of clinical trials. But it will also help us in terms of thinking about the evidence that we need to ensure that we can win some of the arguments about how these therapies are cost effective.
So Joanne, Hillary just brought up access and finances, and that's been a story in the United States as well. Who has access? Can it get covered by insurance? When we talk about women, we should mention, obviously, that not only are women more impacted, but minority women even more so. And so how do we reach people who need these drugs the most, who might be in more impoverished situations, who might not even know they're eligible? How does the system stay ahead of the changing population and those who need the drugs?
Yeah, I am a public health professional, so I always think about things from the standpoint of how are we going to change a community, how are we going to change a system to enable individuals to be in a place where they don't have to ask, but there's a push on that. But at the same time, we know from public health history that change doesn't come from the system. Change comes from individuals who demand change. We saw that with the breast cancer movement. We saw that with the cervical cancer movement. We saw that with HIV. The story repeats itself over and over again. So educating people about what is available, what does it mean to them, what is the value that they could get from that, and then letting them know what should be the required care that they can ask for, I think is a huge part of the sea change we need to see as part of this innovative moment within Alzheimer's and dementia science. So we have to think about, are people aware of their risk? Can we change their awareness level and then give them the information about what they need to be asking for or demanding from their provider? A big piece of that is we know women have a slightly higher concern based on some of the surveys that we've done about their risk of Alzheimer's. It's still way too small. The last time
we did a report this year. We did a status report on women's health overall at the Cleveland Clinic, and only 19% of women were aware that they were at increased risk for Alzheimer's. When they were told that, they were like, give me the information, give me what I need to do, and I'll do it right away. But what are we missing? Everybody in here is an advocate, an agitator, a policymaker, a doctor, a researcher, and working tirelessly in this field. And what are we collectively not getting done? How are we not breaking through with this message that, you know, Alzheimer's, dementia, brain health is a women's health issue to be aware of if you are a woman?
Yeah, I think there are things that we can be doing. There's things that we are doing. But this also requires us to talk about the advances in the science. You and I were discussing earlier, for everybody else in the room, that there have been some incredible advances in Alzheimer's science. But we don't necessarily translate that to the lay public to get people excited or to get them interested. And giving people kitchen table conversations that they can then take to their family members or their friends in an easy and bite-sized way, we've got to think about how do we translate that to people to get it out. Building awareness is also about being able to see that there's a reason why I should have or I should take action. I think some of the prevention trials that are coming, being able to know your biomarker access, being able to message that to people gives them a reason to want to know their status and to make a change. And knowledge is power. So we've got to figure out a better way, a more consumable way to talk about brain health, make it easier to understand, and then also motivate people to know why is it important for you to know your risk or your what you could be doing about that.
So Rachel, let's talk a little bit about that. Everybody that I talk to about that, they're like, well, I don't want to know anything because there's nothing I can do, and so I don't want to freak myself out for the rest of my life, so I'm out. So push back against me. Tell me, I'm somebody who comes to you and goes, I'm not taking that blood test.
Yeah.
No way am I
Yeah.
taking that blood test. Don't even talk to me about this. And by the way, also, I don't want to get it, so now I'm feeling kind of helpless, powerless, and angry.
I absolutely 100% hear that. Wow, Maria coming at you is quite intimidating.
That was a mild version.
Yeah. That's right. So I guess, first of all, what I would say, one thing that I hear over and over and over again whenever I do community outreach or any kind of event like this one, the first thing I like to try to say is that all women go through women go through menopause. They don't all go through dementia. And so this is not always a story of vulnerability or greater risk or susceptibility. There is also an incredible story of resilience. And there are actually very interesting and very promising findings coming out from actually many of the people in this audience who are suggesting that there is a lot we can harness about optimizing brain health coming out from women's research, which could actually be applied to both women and men. So these are things we also need to think about. This is not just a story of fear.
Can you tease that a little bit?
So, for instance, some of our work, and this is not just us, there are many other labs looking at the X chromosome. No one has ever looked at the X chromosome until about 5 years ago because guess what? It's really hard to look at. Men only have one, women have two, and suddenly it's too hard to look at. So everyone just chucked it out. They'd look at the rest of the genome, and that's fine. We found amazing results with many, huge studies showing these are some of the hits. We've got hundreds of, gene hits, including ApoE4 for Alzheimer's disease. Great, that's wonderful. Guess what? The X chromosome also imparts very important information. And not only do some of these genes involve risk, but actually there's quite a lot that are involved with susceptibility. Better cognition, lower levels of tau and amyloid in the brain, and guess what? Not just in women, but also in men. So that is one teaser, and that's just digging below the surface. There are so many potential therapeutic benefits that we could have from just looking at the X, which is so exciting. I could go further, but I won't. But the other piece of this is, I don't want to know. And I understand that. I'm going to disclose, I've done it with Meryl Comer before, I am an ApoE4 carrier. And I did want to know, but I tell you what, I was very fearful when I found out. And it means, in fact, that it goes through my family in some way. And that is what lit a fire under my bottom as well, to really find out what it is in particular, because we know and in fact there's some people in the audience who have really been the proponent of this, that women who are E4 carriers actually stand to be at slightly elevated risk of dementia relative to men who carry the ApoE4. Now, we still haven't fully understood why that might be, but there is certainly this interesting intersection that we need to understand more. And this is why we are part of the Wellcome Trust Care Leap program, to try to understand some of these questions, and there's still more that needs to be done. But what I would also say as a teaser to Wednesday, on Wednesday I'll be showing some of the first findings on p-tau217 in the blood of people who are cognitively unimpaired. And we're trying to build some of the first individualized estimates of risk over 5-10 years. The whole point of that is for us to start to think about p-tau217 like we do cholesterol. Let's get people's blood at some point and be able to really estimate based on your age, sex, education, other factors. We're really working to build robust models now. But this is where the field is going. Now, why would someone who's cognitively unimpaired want to go into a clinic right now and get their p-tau217 checked? My argument right now is we're too soon. I would not want my mum going in to get it checked. I would not want my neighbour to do it right now. It is not currently recommended in the Alzheimer's Association clinical guidelines. However, if, touch wood, we see these promising secondary prevention trials being positive, the game changes. All of a sudden, we will need to be immediately rolling out any of these biomarkers, and p-tau217 in the plasma is a game changer. It is access for all, I hope, much easier than a PET scan. Yeah. And we will be able to very quickly sort of ramp up that machinery, at least in the United States. When we need to get something done, we get something done. And then that will be important. And we need to understand as we go forward, are there differences between men and women, how we think about this? This is still early days.
Yeah, I think there's an important point within there too. Rachel just mentioned the machinery gets going, and that's a big process, because we have to make sure the right people get the right diagnostic that could lead to the right medicine. And that's a big moment within the Alzheimer's research space for us right now. We're going from no diagnostic, no treatment, right, in primary care, potentially to a moment where we're treating it like cholesterol and we're able to deliver a treatment. That requires the health system and physicians and providers to behave differently, but it also requires societies to step in and deliver the guidelines based on evidence-based medicine for that moment. So all of the learning that we're getting from the biomarker data on p-tau217, the details about deaggregated gender profiles for p-tau217, that's going to apply to screening guidelines someday, where we're able to say at what age, at what gender, at what measure within the p-tau217 should you be receiving the next treatment or the next scan, or am I on a watch list, a watchful waiting list for the next 5 years?
You brought that up. That requires kind of a sea change in delivery, but also in education and bringing doctors, nurses, practitioners, those on the front lines, those shared appointments, all of this into the pipeline, kind of the education pipeline. How difficult is that going to be to bring doctors on the front lines into this sea change?
Well, it's never easy to get medical practice to change. And I'm sorry to all the physicians out there in the room or online. But the fact is when you go from innovation to practice, that's about a 7 to 9 year journey. And that's not acceptable. I think we all agree to that. And so we have to tighten that timeline and think about how do we then, going back to that public health story, how do we enable our chief health officers of the home, women, to demand or teach our own communities about that need while we're getting the physicians and the providers to change behavior.
I'm going to go to the audience, so raise your hand if you have a question. But Rachel, I want to come back to you when you said you found out that you were a carrier of the APOE4. What changed in you? What did you change in your lifestyle?
Oh, so I've actually done a lot. I actually now go on the 5-2 intermittent fasting diet. So I'm right now not eating, although I may change that after this today. But I do that 5-2, and my husband started that. We did that 15 years ago, and my mother and father also do it. I run about 10 to 11K twice a week, and I do a lot of resistance training. But I have to say right now, you know, as I said, clinical guidelines for p-tau217 are not recommended. But what I would say is somebody would tell me to do the same intervention to myself, whether or not I had elevated p-tau217 levels, which is, you know, heart health is brain health. Maintain your physical activity. Sleep well, which is hilarious because I have, you know, twins, young twins. So I'm doing the best I can. Eat as well as you possibly can. Whatever your grandmother would make, you should do. And maintain cognitive stimulation. Get out there in the world. Go to London, meet new people, learn a new language. So these are the things that I am doing personally.
So that's adhering to what we now call a brain healthy lifestyle.
Correct.
So when we talk about brain health, which is a way of, I think, helping people, like I talk to my kids all the time about brain health. I'm talking to them about Alzheimer's, but I'm talking to them about, do you think about your brain health? You go to the gym to pump up your, you know, triceps. What do you think about your brain? Are you eating for your brain? Are you thinking for your brain? Are you learning for your brain? Are you letting your brain rest? How does your brain grow? And just these conversations that each and every one of us can have with our families, with our friends, introduces the concept of brain health before mild cognitive impairment and or Alzheimer's. So we have questions? Go ahead.
Not yours. James, do you have the mic?
Oh, that's the only one?
Yeah. Oh, we've got the mic.
Go ahead.
Natalie Rasgan, Stanford. Just a fascinating conversation, very exciting to hear that. I want to bring back the topic of sex differences because I think it's profoundly important. And what sex differences truly mean is not just looking at men instead of women or women alone, but truly doing a comparative study, especially mechanistics and biomarker studies in both sexes at the same time, employing the same methodology. Because then we can do a direct comparison on the biomarkers, how they plan out the risk, the vulnerability, or resilience between the two sexes. For that matter, I wanted to comment on the Alzheimer's Association when there was a project which we were lucky to get in about 2010, 2011, when you were supporting the sex difference study of the modifiable versus non-modifiable risk factors for Alzheimer's disease. And the reason I'm mentioning it is because this is exactly towards where to go to the gym, eat ketogenic diet, or take GLP-1, is because the mechanistic biomarker is very different, and the brain response to exercise could be profoundly different in a woman versus a man. But any exercise will bring the synaptic connectivity and plasticity to a better place, and we know that. So there are many ways for us to really describe now what denotes that specific individual profile.
And you're doing a lot of that at the LEAP, the Welcome to the Care study, correct?
There is a lot of interest in it. Also, what's really exciting is I just found out recently, as a part of a slightly different board, the Sex and Gender and Neurodegeneration Consortium, which is underfunded by the Alzheimer's Disease Data Initiative and Gates Foundation. And what they're doing is going back to worldwide fingers and US pointer and Latin American fingers trial to really get into the nitty-gritty of how women and men differed in their responses to those interventions, those non-pharmacological and lifestyle interventions, and that will be really interesting.
You're also on the Coalition for Women's Brain Health.
Correct.
And I know you're looking at everything going on.
That's right.
With all the studies being done on women, and are going to report out on that. Will there be learnings that that the Alzheimer's Association, the UK Alzheimer's Research, and all hospitals and others can glean from that and put into practice now?
Yes, that's right. What we're doing is we're pulling in experts from all over, pulling in research, advocacy, public health. We're pulling everyone together, all the key stakeholders. We're not just doing a review of where we're at and doing a state of play, but we're also providing recommendations. Where do we need to go? What are the gaps that remain? There are many, but there are really high impact ones that we are either low-hanging fruit or things that need to be known now so we can make huge leaps forward.
I mentioned that WAM is a founding member of that coalition, but there are things going on to report out all the time in real time about sex differences and what we can learn and where are the gaps. Go ahead.
Thank you so much for this inspiring discussion. I'm Shireen Sindhi from Karolinska and Imperial College London. And overall, it's been really promising to hear about the extra funding that has been going towards women's health and Alzheimer's disease. But I think if we can just zoom out for 1 second and look at it from a global perspective, there was a report in 2024 saying that 5% of global R&D is targeted towards women's health, and 4% of that is for women's cancers, and the rest is to the rest. So we can even imagine how minute that is towards dementia and Alzheimer's disease. So I would like to ask, what can be done? What can all of us here do to increase that funding in order to enhance what we know about the whole progression and the whole continuum, from risk reduction all the way to treatments and care?
Well, I think one of the things, that's why I think the Women's Health and Research Center at Cleveland Clinic is so revolutionary, right? Have hospitals develop these women's health and research centers where women can go and have navigators that help them. Oh, you're dealing with depression. Let's look at this. You're dealing with endometriosis. This is a reproductive health thing. This is, every single condition. This is a neurological condition. Go over here. We have far too few of those kinds of centers, particularly in rural America and in rural countries and rural areas around the world, because women's health has not been a priority. But I think women's health is having a boom moment in the United States, and I think President Biden was instrumental, and First Lady Biden, in having a White House initiative for the very first time. I worked with them on that to bring women's health up to the federal level, and it matters. You were talking about having government funding with the Dame Barbara initiative. We don't have that right now. We don't have a president who's interested in women's health. We could, again. This is a political issue. It's an advocacy issue at every country. And it's an issue that women can vote for. If they're caregivers, they can vote for a person who's interested in a caregiving policy to put forward. They can vote for somebody who wants to fund Alzheimer's and dementia research. They can vote for someone who believes in science. They can vote for someone who believes in funding women's health. But that's a different... but that's a real issue. Go ahead.
Hi, Paul Campbell. Thank you for this conversation. I'm from Minetta Health. And the Lancet study, when they're talking about the 14 modifiable risk factors and up to 45% of dementias could be prevented, I think is probably one of the most underreported pieces of good news and hope. What do you think the biggest barrier to getting that message out more broadly and applied?
Yeah, well, I think first of all, we were talking a little bit about what are they. I think the Lancet Commission is a great piece of information that scientists use, but we haven't translated all of really good science to the general public. So I go back to, we have to make science, we have to make things that we can do as individuals consumable by people. And, you know, we like marketing campaigns, right? Let's think about the pink ribbon moment for women and what that meant globally for breast cancer awareness. We need to have our own, you know, purple moment, or you know, whatever color Alzheimer's awareness is in your country moment, right? And really change how science information is delivered and make it consumable to the general public and actionable too, right? Those are 14 modifiable risk factors. Let's think about 3. Let's think about 4. And then let's make some steps around what we can do around that.
I think one of the things, go ahead.
So I think the so Alzheimer's Research UK funded the Lancet report, and I think some of the challenges we have here, you know, there's still, you know, huge amounts of stigma around Alzheimer's disease and dementia, and we can't get away from that. We have to acknowledge that people are terrified of it. So if you're terrified of something, you'll often kind of retract from that rather than come and try and find more information about it. And you know, it's only really in the last sort of 10 years that the sort of, you know, even AIC meetings, there was a lots of conversations around hope, but actually what does that hope translate to? And I think now we can reel off all the things that hope translates to, and the access and tests, and there are treatments, and there are clinics that you can go to. That's changed hugely. Yet we've got to get those messages out there too, because I think when people understand that, you know, there are blood tests, there's diagnostics, there are treatments, there's a pathway, you know, that translates that sort of hope that there is something that you can do in terms of what that looks like. But it's also just that basic message that, you know, dementia is not caused, you know, not sort of an inevitable part of aging, it's caused by disease. All of those things, we have to keep, you know, telling those basic messages, still haven't got through. So, you know, only 1 in 4 people in the UK still really believe that dementia is caused by disease. So that, you know, making that leap from that point to understanding as to, you know, well, what can I do to reduce my risk? One of the things that we got into, there's a health check at 40 that everyone in the UK has access to through their GP. And we made sure that there was a dementia risk conversation within that 40-year health checks. In the first few years of you turning 40, you would have a conversation around a number of things. You would go in, you would have blood tests, they would look at your BMI and your weight, but that would be the first conversation you would have with a clinician to say there are things that you can do to reduce your risk. Did you know about this? Is the way you can go for information. That doesn't always happen, but actually starting to have those conversations is really, really important. But I think once we get to the point where actually it becomes routine, where people are asking for tests, understanding that people are getting treatments, the next generation will be demanding them, and I think that then makes some of our jobs a little bit easier. But I think we have to continually get out there and talk about what it is that we're trying to do and how we're delivering on that message of hope, and that we are cracking this, and actually in the next 5 or 10 years this is going to look hugely different. And that sort of statin for the brain that we've talked about for a number of years, actually we can start to see what that would look like.
Great. Dr. Robbie Britton, also a beneficiary of a WAM grant and a great friend and a legendary woman in this space. Go ahead. I can't imagine what question you have.
Actually, I'm just the cheerleader. You know, thank you so much, Maria, for leading the charge in this endeavor. And, you know, Joanne, thank you so much for all the work that you do. And Rachel, no, sorry, Hillary. Yeah, Rachel, I love you, as you know. Hillary, I really want to thank you and the UK, everyone from the UK, for investing in the UK Biobank, because that data set is absolutely, it gives me the chills, transformative. Yeah, so a round of applause you know, for our UK. And we just analyzed some of the proteomic data that is available through the UK Biobank, and has, you know, really enlightened us tremendously on women's health and, I know, this transition state of the menopause. So thanks to you and all your UK colleagues here in the room and in the nation. Thank you.
Let me just ask, Robbie, where do you think we should be when we gather at AAIC next year? What would be success for women and Alzheimer's that perhaps where we're not right now? What's kind of a like, whoa, that would be great. We can get up and jump.
So
Which,
love
by
that
the way, is
question.
really good for your health at midlife.
I love that question because it was actually some of the UK Biobank data that we analyzed, and presented at a previous meeting at the Welcome Leap, where we were able to find in the proteomic data that is in the UK Biobank that what we saw in our discovery science was showing up in the women's proteomic profiles. So to your question, what are the therapeutics? What is, yes, exercise and walking London and racing to one meeting after the other, as I've gotten a billion steps in. But what are the therapeutics and what are the strategies, both kind of at-home interventions as well as therapeutic interventions that can change the trajectory of risk, right? Coming back to, we want to move the needle on risk because that moves the needle on everybody's life and preventing Alzheimer's. So really thrilled. And I would just want to say one more thing. So for the guys in the room, to Rachel's point about ApoE4 carriers, and it's interesting, some of the data that we have shows that men who are ApoE4 carriers look metabolically like an ApoE3 female, which could actually provide some insights onto why there's a lower risk of developing Alzheimer's in even the 4/4 carriers. Yeah.
Who are male.
Who are male. Now, being an ApoE4 carrier female, that's a risk.
Let me ask you, kind of, where do you want us to be next July?
I think that's a great question. And as we're coming up on the, I shouldn't say coming up so close, but we're coming up on the 20th anniversary of the original report. I think it's an opportunity to think about what happens next, or where do we need to be after that, and then really make some concentrated collaborative efforts around what that could be. And AAIC is, the world's largest convening of dementia science, and these conversations couldn't be a better place for what that could be. So I think there is a significant amount of opportunity, whether it's scientific report out, whether it's women in science that we are seeing a growing number of, or whether it's a effort to make sure that continues to be an important conversation. One thing I might just point out with this scientific conference, if you happen to be at the plenary, you heard Maria say that 52% of the scientists at this meeting are women. And that's been a growing number over time. I don't think that includes our virtual audience, which we know our virtual audience has a tendency to skew even more women because they can participate more. They don't have to necessarily worry about travel. They can still maintain the responsibilities that they may feel that doesn't allow them to travel, but they still get to enhance their resume. And that's incredibly important from a scientific access perspective. We think about access from the delivery of medication, but we also need to think about the access from building women's careers pathways within the science. And the more women scientists we have, the more focus we will have on this topic as well.
Absolutely well said. Hillary, where do you want to be a year from now?
Yeah, so I would say probably, I think kind of the collaboration point is really key. So I think, hearing some of the different things that are happening, some of the brilliant work that a number of you in the room are already doing, I think us all coming together as that sort of movement is really important, sharing what it is we're doing. None of us can do this on our own, and I think that those voices are amplified if we can work together and share some of that information. I think the other thing that I would be really keen to see is women's health strategies, and there's conversations in the UK about an updated women's health strategy, which historically has basically just been around kind of women's reproductive health, looking at women's brain health, and joining up a number of those strategies kind of in the UK, across Europe, in the US, and thinking of what that needs to look like. And I guess, as a funder, kind of increasing funding that is going into a number of these programs as well.
Right, and Rachel, what would you like us to be talking about if we convened with this exact panel a year from now?
Tell you what, I'm so excited for the next 12 months. There's going to be so much change in the field. Of course, for Alzheimer's disease, but also for sex and gender. And you currently are very lucky. You've got some of the leading researchers in sex and gender research right now in the room. And I will say my own piece, but I know they will have their own thoughts. But right now, just in the Wellcome Trust Care Leap program, over the next 12 months, we're going to see major findings coming out. We're looking not just in secondary data, we're also looking at biomarker research, basic science, and also what does brain fog mean? How is that associated with vasomotor symptoms and Alzheimer's disease biomarkers? We're trying to get to the bottom of clinical trials. We're running clinical trial simulations to see how men and women might differ in their responses to not just Alzheimer's disease therapeutics, but others associated with chronic disease. I mean, the list goes on. In amongst all that, we're probably going to be seeing some of the most exciting science in terms of secondary prevention trials yet. In amongst all that, we're seeing biomarker data coming out, and we're really probing sex differences there. So there's a lot to be excited about. Watch this space in 12 months, and we'll have that discussion still going, but it will be our prerogative to get out there and make the case.
Wonderful. And I should say that the three of us wrote an op-ed, speaking of collaboration, speaking of all working together, about how we could have a unified approach and what we could all be asking of not only the public, but governments across the board, which I hope you might check out. It's up on the Alzheimer's Association, up on UK, Alzheimer's Research UK, and up on the Women's Alzheimer's Movement at the Cleveland Clinic. And I hope all of you, first of all, I want to thank you for coming, you especially because this is your party in London. And breaking free from that really means a lot. And I look forward to working with everybody in this room, because I think everybody in this room is a storyteller. I call you a reporter. And to your question about how to get out the Lancet, it's how to get out any of the information you've heard here today. Because if you go to 10 people, I guarantee you they won't know any of this, what you're talking about. And just to begin the conversation about brain health, I always said if women spent as much time on their brains as they did their lips, their thighs, or their eyes, that we would have this worked out, right? But talking about brain health, just getting people aware of what it is, eating for brain health, resting for brain health, asking your doctor, being proactive at 40, at 50, understanding that your kids' age, how that ages, how they will age forward is really instrumental. And young people are, as you said, super excited. I know my kids, I have 4 kids, they know way more about health and wellness. They clean out my house continually while I put everything back from products. They're like, do you know what these products do to your brain? Do you know what you're putting on your face, what it has an effect on your brain? I've created 4 nightmares, but I mean, it's super interesting that people are aware and interested. And so the more we can report out, that we can tell a positive story of what researchers and scientists and advocates and activists are doing in this space to counteract the negative, fearful space that has surrounded this disease for so many decades. And I feel that changing. I'm out in the, more and more people come up to me and say, I'm caring for a parent. I need help. Where can you direct me? I'm caring for a grandparent. I'm caring for a husband. I just lost my husband. These are everyday stories that I'm sure all of you are hearing as well. People want something they can do. They're ready for something they can do. They're ready for a good story. They're ready to put hope into action, and each and every person in this room can be the beginning of that story. And as Joanne said, it begins at the grassroots and it moves out from there. So I leave this conference, I leave this meeting hopeful, inspired. I'm always a little ticked off, but that's a good thing because, you know, I watched my mother take her rage all the way through to death, and it worked for her. So, but I think it's super interesting. If you want to change the world, if you want to change your community, you have to get involved. And seeing so many people want to be involved and fight for women's health, which will in turn change men's health, is the answer, I believe. So thank you all so much for coming, and thank all of you for coming. Bravo. And I just want to say, I want to introduce everybody to Sandy Gleistein, who produced this great symposium, and Aaron Stein. Aaron Stein over here, Aaron Stein is the director, the executive director of the Women's Alzheimer's Movement, and you all met Beri. And so if you get a chance to talk to any of them, consider yourself lucky.